Girish, you can start.
Thank you, Mahendra sir. Thank you, Team IFAS, for bringing me on this platform. After the fantastic lecture by the clinical examination on foot and ankle pathologies, let me add the radiological part in the foot and ankle things so that we can make a final diagnosis based on the clinical and the radiological examination of foot and ankle. Am I audible and visible, sir?
Yes, go ahead. Please start.
Yeah, so in next 20 minutes, my job will be to give the maximum possible understanding about the radiology in the various foot and ankle cold as well as the traumatic pathologies. So let's start with the basic thing first. So a foot AP view, we all are aware that a foot is made up of not many tarsometatarsal joints. But if we look at the foot as a gross, we need to divide the foot into the three parts when we describe the pathology or the radiology of the foot. The foot has been divided into forefoot, midfoot, and the hindfoot. The forefoot it lasts from phalanges to the tarsometatarsal joints. The midfoot starts from the TMT joint, lasts up to the scaphoid joints, and the hindfoot it starts from the scaphoid joint and end to the back of the heel. So whenever we are describing any foot X-ray, AP, or the lateral view, we need to describe the osseous anatomy in the same. I mean, in the lateral also, we need to look for the forefoot, midfoot, and the hindfoot problems. And we have to describe the pathology according to this region-wise description. Now, how we interpret a plain X-ray is the main part of my presentation. What we need to see on the X-ray, in the plain X-ray, we need to look for the bones, we need to look for the clear spaces, and we also we should look for the soft tissue problems. In the bone, we are all aware that we need to see the fracture, we need to see the cortical irregularities, and also we should not forget to look for the sesamoid bone, which are the accessory bones in the foot. The clear spaces we will discuss in the later part of my presentation. We need to look for the spaces between some vital joints. For example, this friend. For example, the clear space in the ankle set. We will look in my presentation. We need to look for some angles which are important to know the actual problems and the severity of the problems, and the soft tissue for the free air, for the edema, or for any foreign body. So let's start with the basic thing first. So a foot AP view, we are all aware that how to take a AP view, but let me just describe for the PG students that you have to keep a foot straight, not in the internal rotation, and beam of the X-ray should be 15°. It should not be the 90°. So it should be the little 15° oblique so that you can focus exactly on the center of the third metatarsal. And this is how you take a AP view. And what it gives the best idea about the medial part of the foot. Medial forefoot, medial midfoot, medial hindfoot. These are the things which you can easily make out or clearly see on the foot AP view. How to take a lateral, the oblique view of the foot. So you have to keep a foot in the 40° inversion and you have to keep the X-ray beam exactly 90°. So here you can look for the lateral part of the foot, lateral midfoot, lateral forefoot, lateral hindfoot. So the lateral part of the foot, lateral three digits can be nicely examined as far as the radiological part is concerned on the oblique. Similarly, in the lateral view, one thing is very important. You have to keep a foot in full dorsiflexion and you have to keep the X-ray beam exactly over the talonavicular joint so that you can take this kind of imaging. And this is a very good view to demarcate the hindfoot problems, midfoot, as well as to look for the soft tissue pathologies in the ankle and foot. So lateral view is important for the soft tissue also. Harris axial view, we are all aware that we have to keep X-ray beam at the 45 to 55°, keep ankle in the maximum dorsiflexion as far as the patient allows you. And this is a view which gives you the idea about the tuberosity angulations. Whether your joint is varus or the valgus, for example, in the flat foot, it is in the valgus, varus foot, it is in the varus. In the traumatic calcaneal conditions, whether the tuberosity is displaced because of the Achilles pull in the varus, you have to look for the Harris axial view. Although it is difficult to take in the acute setting of the trauma, but as far as possible, one should always look for this view. So the Harris axial view is important for the tuberosity. For all the X-ray, you should look for all the bones. These are the basic things in the radiology of every part in the orthopedics. So also you have to look for each and every joint. For example, you can see here IP joint, proximal distal, metatarsophalangeal joint, Lisfranc joint is very important to discuss whenever we are discussing the joints of the foot. The Chapot joints, calcaneocuboid joint, and the talonavicular joint, they are also important when you are looking for the joint imaging. Also, as I said, one should not forget the presence of the accessory sesamoid bone, because there are 14 to 20% of the individuals you get some this kind of bone, and these are exactly a normal bone, but always you get a confusion when we are you looking for the sprain X-ray, that whether it is broken part of the foot and ankle things or it's a normal things. So as you can see here, there's a posterior process of the talus fracture is commonly confused with the os trigonum and vice versa. But the things which differentiate is a rounded margin and the continuation with the primary bone, through which you can distinguish whether it is a sesamoid bone or a chromatic bone. As you can look at here also, the base of the fifth metatarsal fracture is commonly confused with the os ocelli. In the lateral view, commonly the confusion arises between the presence of os tibialis externum and the fracture of the navicular bone. In the oblique view of the X-ray, many times you look at the os peroneum, and we label this as a wrongly label this as a peroneus longus avulsion fracture. So always look at the cortical margins, whether it is rounded, whether it is a sharp margins, so that you can distinguish between the normal bone versus sesamoid bone. The tarsometatarsal imaging, as I said, is a very important part of the foot sprain. So in the AP, you have to look for the continuation of the medial border of the first metatarsal to the medial border of the medial cuneiform. Also, the medial border of the second metatarsal to the medial border of a middle cuneiform. In the oblique X-ray, you have to look for the continuation of the medial border of third metatarsal to the medial border of third cuneiform. And same for the fourth metatarsal with the cuboid. Also, whenever you are looking for the oblique X-ray, you should always look whether the extrusion of the fifth metatarsal base outside the cuboid in the X-ray is less than 3 mm or more than 3 mm. And why they are important? Because the one pathology in the midfoot is a Lisfranc joint problem or fracture, which if missed may create a lot of potential consequences. So let's understand in 2 minutes what is a Lisfranc joint. So it is made up of the tarsometatarsal joints. It allows the supination, pronation of the foot. It has been made up of the sharp, the strong tarsometatarsal ligaments, intermetatarsal ligaments. But if you look at the Lisfranc, so it is basically the base of the medial cuneiform to the base of the second metatarsal, and it replaces, it's basically represents the only stabilizing structure between the medial and the middle column of the foot, and these are the three ligaments which gives the maximum stability to the foot. So how the Lisfranc injury happens? So we know that this is the forced plantar flexion injury, axial load in the forced plantar flex foot, which allows the dorsal subluxation of the base of the second metatarsal, which is a very stabilizing structure in the midfoot. And what happens if you miss it? Unfortunately, 20 to 30% of the time it is misdiagnosed, and it is missed in the plain X-ray, but 50% of the time you may get post-traumatic arthritis. So this is a relevant injury, and you should always look for the power to diagnose and not to miss this injury. So here is an example to sting foot injury. Immediate non-weight bearing X-ray is done, foot AP, foot lateral, and it was labeled that it is a normal. And also, if you look at here, the cortices, as I said, medial border of the middle cuneiform with the medial border of the first metatarsal, they are all aligned. So here, the orthopedic surgeon has labeled that this is a normal X-ray. Look at what happened because of patient having a persistent pain on the walking, persistent swelling. So 15 days post-injury, full weight-bearing X-ray was done, which was showing some problem at the base of the second metatarsal. And what is that problem? But this is a weight-bearing X-ray. And how to take a weight-bearing X-ray? So we need to look for the wood for the wooden frames. so that you can have a similar, that as we have discussed in the first part of my presentation, that how to take the AP and the lateral X-ray. So similarly, you have to take in the weight bearing X-ray, in the weight bearing posture. So 40 days down the line, same patient, if you look at here, the full weight bearing film, it is showing now clearly a fracture of the second metatarsal base and distortion of the margins. And what does that base of the second metatarsal fracture? It's basically a flex sign. So it's an avulsion fracture from the base of the second metatarsal due to the avulsion of the Lisfranc injury, which is a pathognomonic feature of the Lisfranc joint pathology. And also look at the cortices here. We have discussed that if you lost this cortices, middle cuneiform, you will get a clear-cut mode of injury. That look at here, this is a hyperabduction injury. Also, you have a cuboid fracture in the same patient. So now you can understand what is the pathology. It's a hyperabduction injury. So whole of the metatarsal from first, second, third, fourth, they are all disturbed in the hyperabduction, and they has created this grievous injury. Same patient, he has not taken the treatment, he was not ready for the surgery, and look at 4 months down the line, the whole foot is lost, it is very badly deformed, it is gone into planovalgus, and there is an arthritis of the affected joint. So that's why you have to always look for the not to miss the Lisfranc things, and this you can do with the good radiology in the weight bearing setups. Always look for the weight bearing lateral view also, because in the foot, the two X-ray are important for everyone. One is AP and the oblique. Very less people in the orthopedics, they look for the lateral view and weight bearing lateral view, and this is important when you are looking for the Lisfranc injury. So dorsal subluxation of the metatarsals, they are the part of this injury. Always look for the dorsal step. Some injuries are very obvious, you will not miss, but some injuries are subtle, as you can see the right side of the X-ray. There are very minimal diastasis between the base of the second metatarsal and the middle cuneiform. And these injuries that you need, this is our work, the foot and ankle surgeons. This is our duty to pick those injuries on the weight bearing X-ray, on the ideal stress X-ray, so that we cannot miss the subtle injuries. Coming to the next part, angles. Few angles are important in the foot and ankle X-rays. One is a polar angle, so highest point of the anterior facet, highest point of the posterior facet, and the highest point of the tuberosity. So this make this angle normal 20 to 40 degree. If it is less than 20 degree, that becomes that means the joint is depressed, and to which you can assess whether it is severe or not. And Gissen angle, that the angle between the anterior surface and the posterior surface of from the sinus tarsi, and should be less than, uh, it should be between 95 to 105. So if more than 105 is there, that means how much joint depression is there. This is the example here. Look at the Gissen angle. It has been increased to more than 105, and the molar angle has been reduced to less than 20 degree. And according to them, you can assess the severity of the joint depression. Problems in the soft tissues, they also can be well assessed on the lateral view of the X-ray. As you can look at here, there's a calcification in the tendons from the insertion to the mid insertion to the substance of the tendon, and this is a way you can calculate the problems of the dying calcification in the tendon. Pathological rupture, many times we see the X-ray like this, and what is this? This is basically a rupture of the insertion of the Achilles from its attachments due to its ongoing pathology happening since many years. And when you open it, you will find that this is a complete avulsion injury of the Achilles from its base. Broaden's view for the subtalar joint is very important. Again, you have to keep a foot in 45 degree inversion. You have to keep a X-ray at 10 degree, 20 degree, 30 degree, and the 40 degree. And this view is important to know about the subtalar joint congruence. Important when you are looking for the subtalar joint congruence during the fixation of the calcaneal fracture surgery, and also whenever you are fusing the joint, whether it is properly compressed or not, you have to look for the Broaden's view. Canal-Kelly view is important when you're looking for the talar neck fracture fixation. So you have to keep a 15 degree inversion X-ray beam up to 75. and this will give you the idea about the fracture of the middle of the talar neck. Some cold pathologies, hallux valgus angle on the weight-bearing X-ray of the foot should be less than, what is this? So it's a long axis of the phalanx and the long axis of the first metatarsal. It should be less than 15 degree, more than 15 degree. That gives you the idea about the severity. Intermetatarsal angle, so long axis of the first, long axis of the second metatarsal should be less than 10 degrees. If it is more, it gives you the idea about the severity. Some angles in the flat foot assessment is very important. So I will talk about the important angle. The first metatarsal talar neck axis angle is a Meary's angle. On the weight bearing X-ray, it should be 0. If it is the negative value, it gives you the idea about the severity of the plantar uh, and the medial subluxation of the talus in the flat foot. Similarly, calcaneal pitch, so the lower axis on the surface of the calcaneum to the ground surface should be less than, it should be between 20 to 30 degree. So more than 30 degree cavus, less than at 5 degree or 20 degree is part of flat. In the ankle, we are all aware about the three X-ray which always we look, AP, mortise, and the lateral view. How we take it, ankle, for the AP, you have to keep an ankle in neutral, in mortise, 20 degree inversion, and for the lateral, complete 90 degree. And you have to focus your X-ray beam at the center of the ankle joint. And on the lateral view, exactly on the center of the lateral cuneiform. And what we have to look for the ankle X-ray, clear spaces, as you can see here, the medial border of the distal tibia and the medial border of lateral border of the distal tibia and the medial border of the fibula. This is a tibiofibular clear space, should be less than 5 mm. Also, the tibiofibular overlap, the margins appositions in the AP view, it should be more than 10 mm. If anything happening beyond this value, we can assume the diastasis of the fibula from the tibia, and this is a part of syndesmosis injury. The medial clear space in the ankle is again a very important clear space. As you can see here, it is the talus is subluxated laterally, and we are all aware that as long as the deltoid pull is there on the medial talar, it doesn't allow even a 1 millimeter of the shift to the lateral side, and any value more than 5 mm is pathological, and you can look at here that it is 8.5, which suggests the deltoid ligament injury, and you can assess the severity of the injury. Again, a few last slides. Here you can look for the normal X-ray on the left and on the injured X-ray on the stress X-ray. And look at here, it is a widened medial clear space suggesting the deltoid injury. Also, there is a avulsion fracture, which make everything sure that it is a deltoid injury. And also, there is a widening of the tibiofibular clear space, which suggests the associated syndesmotic injury as well. Three common malalignment angles. Also, you have to look for the weight-bearing X-ray in the ankle, which give you the idea about the axis in the coronal and the sagittal plane. So, TAS, the tibial anterior surface angle, and the tibial lateral surface angle, they are all important. We can look at here. The talar tilt angle, as you can see here, the long axis of the tibia and the talus, it has been shifted. So, it is a valgus malunion. TTA is 16, should be 0. Lateral distal tibial angle, the angle between the long axis of the distal tibia and the parallel axis of the joint line should be less than, it should be between 86 to 92. And
3 more minutes, Girish.
yes, sir. And look at here, this is the LDTA, which is showing 104. That again gives you the idea about the 10 degree malunion. What is important, the lateral view, as you can look at here, that long axis of the distal tibia and the long axis of the, the joint line surface, it should be between the 80 to 85 degree. But if it is more than that, that give you the idea about the procurvatum or the recurvatum deformity. And same thing you have to look after the reconstruction, whether it is restored or not. It should be between 80 to 85 days. Radiology in the foot and ankle, the ankle instability. We are all aware that sprain and the chronic ankle instability is not an uncommon problem. So anterior drawer test, you have to give the thrust to the hind foot anteriorly, and you have to look for the anterior subluxation of the talus. if you're looking for the anterior talofibular ligament injury. The same thing for the calcaneofibular ligaments. It allows the talus to move into the mortise, goes into varus if it is broken. Weight-bearing X-ray of the ankle is very important, and impact you can see here. So one is a non-weight-bearing X-ray and one is a weight-bearing X-ray. You can look that how much amount of the anterior tibial impingement is there on the weight-bearing X-ray, as well as the anterior talus subluxation, which is commonly missed in the non-weight-bearing X-ray. So
1 minute to go.
yeah, so these are my concern about the radiology. Thank you, sir, for this opportunity, and your all questions are invited on this platform. Thank you, sir.
Thank you, Girish. It was a very comprehensive presentation once again. Uh, a few points I would like to make for all the beginners, the postgraduates. Just make a habit to go to the X-ray department and do the X-rays yourself. That's rule number one when you start, because your technicians probably won't be able to do it. So once they get into the habit, it's fine. And try to do all the views as much as possible, because what the eye see, the mind knows. But if you can't see it, then you won't make the diagnosis. So it is very important to get all the views. And before saying it is normal, I think it's very important to also do the, as Dr. Girish has said, these dynamic views, the stress views, because a static view, you may miss the lesion, especially in a trauma situation. The instabilities may be missed. So it is very important to do the dynamic views. The one point that I would like to make on the clinical examination is that I think a proper understanding of the history is extremely important. Understand the nature of the pain. Ask what type of pain it is, for how long it's been there, because the nature of the pain itself can clinch you the diagnosis. So I think if you have a very detailed clinical examination, listen to the patient properly, I think 80% of the time the patient will tell you the diagnosis. Do not neglect any complaint of the patient, because that is one that might lead you the rare diagnosis. So it's very important that do a thorough clinical examination after a detailed physical examination and a detailed clinical history. And once you have come to your differential diagnosis that Dr. Kamal Dureja has mentioned, it is important to confirm your diagnosis by doing a detailed radiology. Now, Dr. Girish has given an excellent way of how to go about it. Once you have done your X-rays, and after doing your X-rays, probably 20-30% of the time you would like special investigations like a CT or a dynamic CT or an MRI. And it is something that, to confirm the rare diagnosis. But please remember, keep it simple, but keep it predictable. All your investigations have to be having a format, and create a format so that it helps you in your clinical practice. With this, I think we are.
Do we have any questions, Mahendra?
Any more questions?
Do we have any questions?
No, sir.
We're not having any questions. Okay. One thing I would like to say about the medial clear space. So there was, something like mentioned 5 millimeter. It is really a challenge that should we take it as a 5 millimeters or not. There are certain studies which take 6 or even up to 7 millimeters normal, but we don't have any conclusive evidence what is the medial clear space. Manut wants to say something about it.
I think if you have any doubt about this, try to compare it with the other side. It's a very good habit to compare your X-ray with the normal side, because sometimes, as Dr. Rajiv said, that there could be a variation. So if it compares to the normal side, I think you are safe enough.
So that is, any other faculty wants to add something?
Yeah, Girish has done a wonderful work about list frank injury, so he has really unburdened me a lot. Thank you so much.
We have 3 more minutes before we move on to the ankle, the fracture session. Any faculty, Maninder, you would like to add something? Or I think everything has been very beautifully dealt both by
Dr. Kamal,
Kamal and
Dr. Kamal, can you say a few words if you want to complete your presentation?
Can I add one more comment, Mahendra, before summarizing?
Yes, tell me.
So just I wanted to ask Girish, since we have 2-3 minutes, what would be his indications for getting a CT scan? So we know in foot and ankle we order a lot of MRIs. What is his indications, or what are the indications for the faculty for the CT scans for the ankle? Other than a
Girish?
trauma case, other than a trauma case.
Correct. So, so there are many conditions where you can order the CT scan. If you look at the traumatic conditions, I think this Frank,
Non-traumatic case. Non-traumatic case.
in the non-traumatic case, so when you're looking for a kind of type 3 deformities of the adult acquired flat foot, you need to look for the joints and the cartilage. So many times to know the subtalar joint pathologies, arthritis or not, we need to order the CT scan. Also in the cavus foot deformity, whenever you're looking for you're planning for the reconstruction or osteotomy versus fusion, you require a CT scan. Better comment on the.
There's
I
one
think
There's a one
question.
question there. I can
Yeah.
just
Yeah.
that whether we
So,
should take a weight bearing view immediately in a list franc. I think if the patient cannot weight bear on any after any injury, please suspect a severe injury. That is the point. I mean, the key point is if the patient cannot weight bear, and even if the X-ray is normal, don't let it go. You have to investigate this. You can take a CT scan if your X-ray, if the patient is not able to do a dynamic weight bearing film, subject him to CT scan because you might pick up a small flex sign there.
But Mahendra,
can I answer that question? Can I answer that question?
Yes.
Yes. So if there is acute suspected Lisfranc injury and the patient is not able to bear weight, some authors suggest that we can put some kind of block at the ankle, like ankle block, so that the pain is gone, and then the patient probably can be
Yeah.
made to take
That's
the weight.
Mahendra,
a
there
valid
is
point.
another way. You can make the patient sit comfortably on a chair and ask them to put as much weight as they can, because now that is not a 100% full standing weight bearing. But
Yes.
yeah, the pressure given may be sometimes sufficient to demonstrate a minor displacement or increase in the
Yes.
space.
Point taken. Point taken.
So what I have seen in my practice is majority of the time the Lisfranc patients, I mean, when the injuries are subtle,
Yeah.
when the injuries are obvious, you don't require access to weight bearing X-ray. But when the injuries are subtle, majority of the patient they can manage for 1 minute weight bearing on the affected foot. If anyhow the patient are obese, is a fatty lady, not able to manage, we can take the subtle, I mean the injuries X-ray on 7th day, 8th day after the few brief period of immobilization.
Okay,
Yeah.
fine. So, Girish, thank you. We have already
Yeah.
concluded
Thank you
the
very much.
session.
I
I
think.
think we will go hand over to the next session
Yeah.
to Dr. Rajiv Vora on foot and ankle trauma.
Okay.